Cerebrovascular disease. On gross examination of pathology specimens from patients with cerebrovascular disease, you can actually note how far out you are from the injury based on what is seen. Grossly, at 0 to 12 hours, there's really no change seen in an infarct. Whereas between 12 to 24 hours, there are minimal changes, and 24 to 48 hours, there are indistinct gray-white matter junction problems. Notably, the gray-white matter junction is harder to differentiate. As time goes on, 2 to 10 days, there is friable tissue and marked edema. 2 to 3 weeks, the tissue liquefies, undergoing liquefactive necrosis, and at 3 weeks to a few months, you have a fluid-filled cavity demarcated by a gliotic scar. This is the remnant of where the infarct occurred and killed off the neurons. Years later, you may have an old cyst surrounded by a gliotic scar, and if it is a cortically based lesion, that is that the stroke involved the cortex, as opposed to the subcortical area, then this could serve as a nidus for seizures. Microscopically, again, 0 to 12 hours, there are no changes. However, something to keep in mind for the USMLE exam, at 12 to 24 hours, you will see red neurons. Red means dead. Red neurons seen at 12 to 24 hours are hypereosinophilic neurons with pycnotic or shriveled up nuclei that represent dying cells. At 24 to 48 hours, there are neutrophils that are coming in to clean out the dead cells. At 2 to 10 days, histiocytes come in to start the fibrotic process of laying down a scar. At 2 to 3 weeks, you have liquefactive necrosis continuing, where the old cells are continuing to die. And at 3 weeks to months, you have a fluid-filled cavity, reactive astrocytes that are making new fibrotic scar tissue, and lipid-laden macrophages that are cleaning up the neutrophils and the dead neurons. Years later, you will have some gliosis with fibrosis around it, around a central cyst. There are different kinds of infarcts. Watershed infarcts are wedge-shaped areas of infarction occurring in regions of the brain and spinal cord that lie at the most distal field of arterial circulation. Watershed areas are areas in the brain that are at most risk of dying. Think about it this way. Imagine that you have a strip of grass that is shared by two neighbors. It is watered by both of their sprinkler systems. However, their sprinkler systems are really feeding their own lawn, and it is this small strip of grass that's shared between those two areas of perfusion that is most at risk. So that if they turn their sprinklers off one day, or they turn the pressure down one day, that little strip that is dependent on both of those areas to get its water will die off. Well, the same thing is true in the brain. There are areas in the brain that are dependent on two different vascular supplies, and if the pressure is decreased in either one, that area is most at risk for dying. We call that area a watershed area. So a watershed infarct is usually wedge-shaped, and it's usually between two vascular territories, say the MCA and the ACA territories. Hemorrhagic infarctions appear like ischemic infarction, but they have blood extravasating within the tissue, and there may be some resorption. Different types of focal cerebral ischemia can be due to thrombosis, which is usually due to the process of atherosclerosis, arteritis, which includes syphilis and tuberculosis as causes of infection and inflammation of blood vessels, and embolism. Embolism can be coming about from emboli in cardiac mural thrombi. For example, if a patient has atrial fibrillation, they're going to form clots within the heart atria that can then go to the ventricles, and from the ventricles up to the brain and cause stroke. Moreover, a patient with a carotid stenosis can have a plaque in the carotid artery, and that plaque can break off pieces that embolize up into the brain. What are some clinical manifestations? Anterior cerebral artery distribution strokes result in weakness and sensory loss in the contralateral leg and a transient expressive aphasia. Middle cerebral artery strokes usually give rise to the contralateral hemiplegia and gaze palsy. The eyes will look to the side of the infarct. Contralateral sensory loss and aphasia are also seen, and posterior cerebral artery strokes will give rise to contralateral hemianopsia, which is loss of vision on the same side of both eyes. Multi-infarct dementia. Here you have cerebral atherosclerosis. It presents as a slow, stepwise decrease in mental function, sometimes over the course of years. We believe that this may be due to small strokes that are taking place throughout the brain and over time lead to dementia. It's important to distinguish this from Alzheimer's disease and other causes of dementia. If you prevent the strokes from occurring, you may be able to prevent the dementia from progressing. Let's do a review question. A 68-year-old woman trips and falls down a flight of stairs but does not lose consciousness. About 36 hours later, she develops a headache with confusion. When seen in the emergency room, she is still conscious and has a scalp contusion on the occiput. The most likely location for an intracranial hemorrhage in this situation is where? A. Pontine, B. Subarachnoid, C. Medulla, D. Epidural, or E. Subdural. Well, the fact that this patient fell, did not lose consciousness, and presented 36 hours later, this goes along with a subdural hematoma. Subdural because it is after a fall, she is an elderly patient, and she had some confusion and headache, which goes along with subdural. Had it been an epidural, she would have had a severe headache, and 36 hours later she would not have been alive. Pontine, medullary, and subarachnoid would have associated neurological findings besides just headache and confusion. Let's talk about acute meningitis. This is inflammation of the meninges and cerebrospinal fluid within the subarachnoid space. It's usually caused by infection, but may also be from chemical irritants and malignancy. Acute bacterial meningitis can be caused by various organisms that depend on the age of the patient. Neonates usually have E. coli or group B strep as the cause for meningitis. Infants and children have H. flu, which is almost eradicated with the vaccination that we now have. Adolescents usually have Neisseria meningitidis, and elderly patients have strep pneumonia or Listeria monocytogenes as a cause. Obviously, each of these lead to different therapeutic measures. The clinical features for all bacterial meningitis, though, is the same. Headache, photophobia, irritability, change in mental status, neck stiffness, or what is called nuchal rigidity, or the combination of neck stiffness, photophobia, which is meningismus, and lumbar puncture will show cloudy or purulent cerebrospinal fluid, increased pressure, increased protein level, low glucose level, and of course, elevated white cell count. Acute viral meningitis, or aseptic meningitis, is characterized by some meningismus, but usually fever and altered mental status, but very mild. The etiology for acute viral meningitis includes enterovirus, echovirus, Coxsackie virus, poliomyelitis, and HSV. Acute viral meningitis can be diagnosed again with lumbar puncture, where you will see lots of white cells, predominantly lymphocytes, rather than neutrophils, which are seen in bacterial meningitis. Moderate protein elevation, more importantly, normal glucose, which is different than bacterial meningitis, which will have a low glucose. A brain abscess is defined as an acute focal suppurative infection of the brain parenchyma. Here, for one reason or another, an infection has set up shop in the brain. The findings are usually focal neurological defects that, depending on where the abscess is located, headache, fever, elevated CSF white cell count on LP, elevated CSF protein, and usually a ring-enhancing lesion is seen on CT or MRI. Here's a gross specimen showing you a brain abscess, and you can see the ring around it. That is the typical action of an abscess. It builds a wall around it, usually composed of your own body's neutrophils trying to attack the abscess, but unable to get through completely. Chronic bacterial meningoencephalitis can also include tuberous meningitis. Here the patients have a history of tuberculosis. They can have headache, malaise, altered mental status, and vomiting. When you do an LP on these patients, you'll see a moderate increase of lymphocytes and neutrophils, elevated protein, and a normal or moderately reduced glucose level. The key test, though, for these patients is AFB. The acid-fast bacillus test will show you if they're positive for Mycobacterium tuberculosum. Encephalitis. Arbovirus viral encephalitis will lead to altered mental status. Here you have a direct infection of the brain by a virus. You may have a neutrophilic pleocytosis, or an elevated neutrophil count in the CSF that rapidly converts to lymphocytes. The protein level will be elevated, but again, with any other viral process, the glucose is normal. Neurosyphilis is typically seen in the tertiary stage of syphilis. Again, you'll have a meningitis involving the base of the brain, affecting the cranial nerves, and it involves invasion of the brain by the treponema pallidum that causes syphilis. You can also see a progressive dementia in these patients. Cytomegalovirus. Cytomegalovirus causes infections of the nervous system in two groups, fetuses and the immunosuppressed. In utero, it will cause a periventricular necrosis around the ventricular spaces, with severe brain destruction followed by microcephaly. You'll see prominent cytomegalic cells with intranuclear and intracytoplasmic inclusions. These are sometimes described as owl eyes. Polio. This is a CNS infection that manifests initially with meningeal irritation and aseptic meningitis. It is the attack by the virus of the anterior horn cells with loss of motor neurons. You'll have a flaccid paralysis and muscle wasting and hyporeflexia, with death occurring from paralysis due to weakness of respiratory muscles. Again, polio has been eradicated by vaccination, but there are rare cases reported in the third world. Rabies is transmitted by the bite of a rabid animal. Again, the rabies virus causes a severe encephalitis. The virus enters the nervous system along the peripheral nerve from the wound site. It causes contracture of the pharyngeal muscles, and swallowing produces foaming at the mouth. The patient is unable to swallow their own saliva, and it forms a froth. It progresses to meningismus and to a flaccid paralysis. It can lead to death within days to weeks. On examination, you will see Negri bodies. That is the buzzword for rabies. Negri bodies are inclusions found in neurons, and here is a picture depicting a Negri body. It is the arrow indicating the small ovoid shape next to the nucleus within this neuron. PML, or progressive multifocal leukoencephalopathy. This is another viral encephalitis caused by the JC virus. The virus preferentially infects oligodendrocytes. Remember, oligodendrocytes are the Schwann cells of the central nervous system. They make the myelin that coats the neurons. So, if you have defects in oligodendrocytes, you have demyelination, because oligodendrocytes are constantly making the myelin. JC virus is in all of us. However, in immunosuppressed and HIV patients, it is allowed to replicate and infect many oligodendrocytes. Therefore, they develop the disease. It's an irregular, ill-defined destruction of white matter and can lead to mental status changes, seizures, and even death. Cerebral toxoplasmosis. It's caused by Toxoplasma gondii, one of the most common causes of neurological symptoms and morbidity in patients with AIDS. On CT or MRI, you will see multiple ring-enhancing lesions, which represent abscesses caused by this protozoa. It is an AIDS-defining illness and a torch organism. Transmissible spongiform encephalopathy. These are the prion diseases. Two important ones to keep in mind for the USMLE include Creutzfeldt-Jakob disease and Kuru. All of these are associated with abnormal forms of a specific protein called the prion, which is infectious and transmissible. The idea is this: the prion protein is usually a normal protein excreted by neurons. The prion protein undergoes a conformational change from alpha helix to beta sheet when this infection is occurring. The prion protein acquires relative resistance to digestion with proteases when it is in the beta pleated sheet form. So, if the body is exposed to the beta pleated sheet form, then its own good alpha helix form prions will become indigestible by proteases and will start to accumulate. That's the hallmark of prion disease. The infectious nature comes from the ability to corrupt the integrity of normal cellular components, where the beta pleated sheet form starts to accumulate and kill off neurons. It is called a spongiform encephalopathy because the brain starts to look like a sponge. You start getting vacuoles or holes throughout the brain parenchyma where normal tissue should be. Obviously, this leads to a rapid progression of dementia. Microscopically, you'll see the spongiform transformation as well as the vacuoles in the neurons and neuronal loss. The clinical features of CJD, or Creutzfeldt-Jakob disease, include the rapidly progressive dementia, usually occurring in the 7th decade. Most of the cases are sporadic, although there have been cases of mad cow disease where there has been ingestion of infected beef and that beta-pleated sheet form has infected the normal alpha helix protein in the person who digested the infected beef. Subtle changes in memory and behavior are followed by rapidly progressive dementia with involuntary jerking of muscles called myoclonus. Finally, there is Kuru. Kuru is a disease of a tribe in New Guinea which ate the brain of dead relatives. Again, that would incite transmission of this rare disease, so one person could infect many, many people. Let's do the question. A 25-year-old previously healthy female has acute onset of confusion and disorientation followed by a seizure. A drug screen is negative. The patient is afebrile and normotensive. A CT scan of the head shows hemorrhage of the left temporal lobe. Lumbar puncture is remarkable for a few monocular cells. What is the most likely etiology for her condition? The correct answer here is actually HSV, herpes simplex virus. Why? Because herpes simplex virus is the most common cause of acute onset confusion, disorientation, and seizure, or complex partial seizure, in a young patient who otherwise has no other findings clinically, and on CT has small hemorrhage of the temporal lobe. Herpes virus likes to set up shop in the temporal lobe, and you'll see hemorrhage in response to that. Cytomegalovirus, Neisseria meningitis, Naegleria fowleri, and Aspergillus would all give you a different picture involving high fever as well as other neurological deficits. This ends the infectious part of the pathology.